So the next MLA presentation topic is Limp. Limp. So what we're going to talk about actually, rather than Limp, is gait issues and how we assess walking and altered gaits in neurology, the different problems that can cause it, and other problems that can affect walking that may not be due to a neurological problem. And I think I do need to say that as far as I understand it, and most neurologists would understand it, the term limp is a non-neurological term or a non-medical term really, in which somebody favours one leg above the other. And traditionally this is because they've got pain in one leg. And with limps, often there's a musculoskeletal problem. People can have an acute limp when they have a sprained ankle, for example. I would generally say that limp is a non-neurological issue. People can have a limp together with other features of what we call an antalgic or a pained gait, when there's a lot of pain when they're sort of walking. So rather than limp, let's talk about types of abnormal gait. And I'm just going to go through a few, give you a little bit of context and describe how they look. So a hemiplegic gait, so we've talked about people who've had stroke, for example, that have weakness down one side, often after a stroke. You would get weakness of that arm and leg, and you would get you will get a pyramidal distribution of weakness, and that means a sort of anti-gravity central nervous system pattern of posture. So the arm is flexed generally, and the leg is extended, and we call that anti-gravity because in nature, if you have extended legs and flexed arms, you're much more likely to survive. So you can walk just about, and you can feed yourself. If you imagine the reverse, so if you flex both your legs and extend both your arms and try to stand up, you'll know what I mean. You wouldn't survive in nature for very long. The gait is often what we call circumducting. So the leg is sort of straight and it often sort of swings around in order to let people step. And with the flexed arm, that's sort of very characteristic of people rehabbing after a stroke or maybe having had a brain tumour. And you'll see that in stroke units. A scissoring gait. So that's what we would call the sort of gait that people would have when they have spasticity or increased tone and increased reflexes in both legs. The legs sort of, the adduction, so adduction, sort of going inwards, is stronger than abduction, going outwards. So the feet almost sort of cross over each other, like if you imagine a pair of scissors. We see that in spinal lesions, but characteristically we tend to think of scissoring gait in severe multiple sclerosis. There are also genetic conditions that cause leg spasticity we call spastic paraparesis. So, and that literally means, spastic both legs. And when you examine these patients, you'd expect increased tone, increased reflexes, and upgoing toes. Sensory ataxia. So sensory ataxia is a sort of characteristic gait or walk you get when you can't feel your feet, particularly the dorsal columns. So there are forms of sensory problems you might get after sort of B12 deficiency, for example, where people just don't know where their feet are in space. So they tend to be quite steady if the light is up and they can look at their feet. But then if you ask them to look up and not look at their feet, or maybe turn down the lights, their legs will sort of separate, so they'll have quite a broad-based gait to increase their balance, and they'll become more unsteady. And people characteristically might have B12 deficiency, diabetes, that sort of thing, and they'll say, I'm all right during the day, but as soon as it gets dark or I go to the toilet, I fall over, or I'm fine until I get in the shower and I close my eyes and try and wash my hair, and then I fall over. And when you examine them, you'd expect to find proprioceptive, as in where are my legs in space issues. So they wouldn't be able to detect vibration or joint position sense. The other form of ataxic gait is what you'll probably think of, which is a cerebellar ataxia. So these people have normal sensation. So you'd check their vibration sense, it would be normal. But they'll have a broad base because their legs are incoordinated, and they might have other features of cerebellar problems like slurred speech, nystagmus, dysthyrochokinesis when you ask them to tap a repeated rhythm or pattern. And the important thing to distinguish between these two is one would have the proprioceptive sensory abnormality and the other would have the other features like nystagmus and slurred speech. Now, in Parkinson's disease or Parkinsonism, you can see lots and lots of differences in gait. I say Parkinsonism because I look after people with things other than Parkinson's disease, such as MSA and PSP. So an early sign of Parkinson's could be reduced arm swing on one side, and that could be it. It's quite subtle, but it's really sensitive to picking up early Parkinsonism. And then later you can get a reduced stride length. That can progress onto almost a shuffle where the feet stick to the floor. A progression of that would be freezing of gait, where people just stick and they can't move. They particularly get that when they go through a doorway. The most profound version of that is what we call gait initiation failure, where people just stick dead and they just cannot move. And we see that in severe Parkinson's disease, but also atypical Parkinsonian disorders like progressive supranuclear palsy. And as well, they can get something called an anti-collis gait, where the neck is sort of flexed forward. So neck flex forward, reduced arm swing on one side, and then the reduced stride length. There are a number of different characteristic gaits you would see in functional neurological disorder. Probably too many to go into specifically, but two of the most common ones that we tend to see is something called a log rolling gait, where one leg is just sort of dragged behind. That may switch from side to side, so they may drag one leg behind them, and then on later examination they may drag the other leg behind them, but the leg is strong and there's no sensory disorder. And the other one is called atasia-abasia, which is where people have a sort of extreme sort of lurching of balance. They sort of go back and forward, they're on one leg, and it seems really unlikely that they could keep their balance so that as they're moving so much, yet they do. And that's also sometimes called walking on ice, where people sort of are very precarious, they're on one leg, and actually that sort of action is harder to balance than a normal standing and walking. A high steppage gait occurs in a foot drop. So if you imagine you dorsiflex the foot in order to let it clear when you're taking a step, if that movement is weak and the foot is flopping down, in order to stop it catching and tripping you up, you have to lift the knee higher. So the knee comes up very high, and that's what we call the high steppage gait. It's a compensatory measure. A few other abnormal gaits. So we have dystonic gait. So somebody has dystonia or abnormal posture of a leg. It's often an ankle and the foot, and it's turned inwards. And you might see they might lift that foot quite high as well. And it may look a little bit like a foot drop, but it's the in-turn that would give that away. In things like Huntington's disease, where there's a hyperkinetic movement of chorea, so that's a sort of semi-purposeful, dancing, flowing, fidgety sort of movement, that might affect the walking as well. So people might sort of walk with this sort of flowing extra movement, and they sort of might incorporate that into their steps. And quite often, particularly in early Huntington's disease or mild chorea, we call it semi-purposeful because it can almost be hidden with sort of extra movement. So people sort of like brush their hair away and sort of do little movements like this. And instinctively you feel quite restless when you see this sort of movement. And that's what we would see in a choreiform gait, classically in Huntington's disease. And a myopathic or a waddling gait is what you get when you have weakness of the pelvic girdle muscles, which stabilize the hips. And you just sort of get a sort of side-to-side movement. And people just almost don't lift the legs up very much, and they just sway from side to side. And the last one I'll talk about is a Trendelenburg gait, which again is to do with problems with the hip muscles. So if the hip abductors are weak, so turning the hip outwards, you will get this Trendelenburg gait. So when you lift one leg up, the leg on the floor should lift the hip a little bit to support the weight. If those muscles are weak and it drops, then you get a sort of lurch. And if they're weak on both sides, you get more of a waddle, like we talked about with the myopathic gait. So gait is a really important part of the neurological examination. And my professors, when I was training, used to tell me, because I'm a movement disorder specialist, if you don't have a pretty good idea of what the patient has when you've walked them into the clinic room, then you're probably not going to get much more out of your 30-minute consultation. And that is true. And that's why I never use an automated system to call my patients in. I always walk out to the waiting room, call my patient, see how they get out of their chair, and see how they walk with me to the clinic room. And all my professors are right. 9 times out of 10, in my movement disorder clinic, I know what the problem is before we get to the clinic room. The gait can guide further examination. So, for example, if you've got a waddling gait or a Trendelenburg gait, you would then do a hip examination and see if there's any evidence of hip muscle weakness or hip injury. If you find sort of Parkinsonian features, you would then focus on neurological examination, looking for other features of Parkinson's disease, and obviously take an appropriate history. And I hope that's given you a little bit of a guide of abnormal gaits. Maybe less about Limp, but we gave Limp the attention it needed, I think, which was a single slide. Thank you very much.